Most of you know Janet. She's an assistant professor of urology. She joined us a couple of years ago and did her undergraduate and medical training at University of Missouri in Kansas City, and then went to do a residency in urology at the University of Rochester, and then a fellowship at MD Anderson. And our division of urology is strong in many things, but I would say our urologic oncology capabilities have really soared in the last several years since Janet joined us and several others. And it's something I'm really proud of. And today, we're going to hear about catheter-associated infections, which has plagued our hospital and actually all of our hospitals. And we're very often outliers when you look at our CAUTI rates compared to rates around the country. So Janet, we're willing to learn from you and look forward to your talk. Thank you.
Thank you, Dr. Schulich. All right, so catheter-associated urinary tract infections. So I have no disclosures. What we're going to talk about today is we're going to talk about what is the definition of a urinary tract infection, why are CAUTIs important, review kind of where we're at with our CAUTIs, and we're going to do some group questions. So I know everybody hears CAUTI, and this is kind of how they feel. This is my house Saturday after lunch. So hopefully this will be a little bit more exciting than that. This is what we call a word cloud, and this is kind of what somebody else had done. And you can see here, there's a whole bunch of different things, annoying, treatment, antibiotics, all that stuff. So we're going to start with a word cloud on kind of how everybody feels about urinary tract infections. And what that's going to do is that's going to get everybody into poll everywhere for our questions later on. All right, so it looks like we have a few things here: recurrent, preventable, complication, inevitable is an interesting one, sepsis, elderly. All right, we're going to go ahead and move on now, but thank you everyone for participating in that part. So urinary tract infections are the most common hospital-acquired infection. So, and this is about 30% of hospital-acquired infections are urinary tract infections. So it's a large portion, and they can be very serious. So the Vizient reporting is what we're using now, and you can see the Vizient uses the CDC definition, and so this is just the definition here. So urinary tract infection where an indwelling urinary catheter was in place for more than 2 days before, and this all has to be inpatient. None of this is outpatient. And so it's either on the day of device placement or the day after device placement. And if it was in place for 2 days, the date of the event of the urinary tract infection has to be the day that the catheter was discontinued or the next day after. So it has to be in a very short, close proximity of what timing the catheter was placed. So a little bit of a review of the evidence from the CDC. They have guidelines for prevention of catheter-associated urinary tract infections. So for operative patients who are have an indication for an indwelling catheter, the recommendation is to remove the catheter as soon as possible, preferably within 24 hours. And intermittent catheterization is preferable to indwelling catheters at so regular intervals so that they don't develop bladder distension. The most recent Cochrane review was done in 2014, and they looked at 26 trials for over 12,000 patients were included. And so the comparison was looking at, is there any use to these silicone catheters that are covered in silver, antibiotics, etc. And they didn't find that there's any difference or that these were helpful at all. So the best approach is to reducing these urinary tract infections, reducing the number of unnecessary catheterizations, and reducing the time period that people are left catheterized. So what does that mean? So if you have someone with a urinary catheter for at 20 days, 100% of them are going to be colonized. But if you look at even by day 4, up to 60% of patients can be colonized on their catheters, and these colonizations are what leads to the urinary tract infections. So this is what Dr. Schulich was referring to, and you can see here that we have been consistent outliers. So anytime you see those blue bars, the entire bars above the yellow line there, our standard incident ratio is elevated. And you can see we are still a statistical outlier here at the end of 2019. So why is this important? Why are the amount of urinary catheters we're placing significant? Well, we place a lot of urinary catheters in the operating room. Perioperative is responsible for a large portion of the urinary catheters. So just in January of this year, almost 687 catheters were placed between AOP and AIP. This is inclusive of everybody. This is all service lines, so it includes urology and any reconstructive surgeries we're doing with that. But in general, the amount of catheters we place is huge. So this, looking at this, you can see the day of catheter removal. So by postoperative day 2, 117 catheters were still in place. So all those catheters are now subject to the Vizient CAUTI data. And all of them are developing the colonization. So this is just the inpatient ORs here, and you can see 102 of those 117 that were left in after surgery were from the inpatient operating room. And at 15% of these at post-op day 2 or greater were still in place. So follow me once, joke on you, follow me twice, CAUTI. So the reason I'm talking today about this is because I'm part of a perioperative team that's leading the quality initiative to try and improve our CAUTI rates. So this has been done previously. We have explored why this has failed previously. There's not necessarily been a focus on CAUTI specifically in the perioperative period. So we are focusing on patients as they come into the hospital. They go from pre-op, and for those that are able to, they void before they go to surgery if they're not going to get a catheter. They go to surgery, get their catheter, focusing on early catheter removal or no catheter removal at all. What we've done so far as part of our team, we've surveyed nurses as part of the perioperative pathway, so both PACU and postoperative nurses. We've reviewed the CDC best practices. We've also, Josh Billings took this on and did a wonderful job contacting the Vizient top 10. So over here on the right side of the screen, you see these are the people or the places in the United States that are the top 10 performers. So the CAUTI SRI, that's the standardized incidence ratio. So instead of being on top of that yellow line that we just showed with our data, all of these people are well below that yellow line. And they had some really great strategies for us to consider. We looked at all of these strategies together, and we've talked about the time versus effort of proposed interventions. So the next step in this pathway is coming to you, coming to the Department of Surgery and getting you involved and having you help us decide how the Department of Surgery wants to proceed. So we're going to do some more poll everywhere. You should all still be logged in from the word cloud. And these are just exploratory questions to kind of try and figure out where we are as a department and kind of what the best way for us to move forward for our interventions are. So how often do you think your patients, or do you observe a patient with a urinary catheter a day longer than needed because the team did not write for removal? Okay, so it looks like we kind of stopped getting responses there. Okay, so we're going to move to the next one. After what duration of surgery would you feel comfortable moving the urinary catheter in the operating room? So this would be you place a catheter and your surgery goes for 3.5 hours. Would you feel comfortable moving that catheter before the patient left the operating room and went to the PACU? Okay. looks like for most cases that are less than 4 hours for everybody would be acceptable to catheter removal prior to going to the PACU. That's great. So when a urinary catheter remains in past postoperative day 1 in your typical patient, what's the most common reason that these catheters are being left in place? So A, concern about potential for urinary retention. B, physician preference because of impaired mobility or pain with mobility. C, patient's preference because of impaired mobility or pain with mobility. And removal was not ordered by your team. And this is just excluding if you think that there's reasons for like urinary tract reconstruction that they might be remaining in place. This is just a typical postoperative patient. And epidural would fall in concern about potential for urinary retention or impaired mobility. But hopefully they're still up and walking around with epidural. All right, great. So it looks like most people are concerned about urinary retention or about the physician preference because of impaired mobility or pain. All right, so this is the last one, and I'm hoping to take this back to our perioperative UTI task force. These are preventable interventions, and we want to know what you think would be the most effective at reducing the incidence of catheter-associated urinary tract. So it looks like the majority of people believe removing more catheters in the operating room would be the most helpful, followed by substituting indwelling CIC. Right. So that was something that we talked about in the perioperative task force, and we were hoping that everybody would agree with us. So the first question that we are proposing that we ask is this absolutely necessary? So for those placements that you're doing in the operating room, if those cases are less than 2 hours, is it absolutely necessary that we're putting in a urinary catheter to start with? If you never put the catheter in, then you're never introducing the colonization into the bladder that can be introduced. And then the next question is, when is it coming out? So hashtag take it out. So the working committee has proposed several ideas. The idea is the way that they're going to be implemented is going to hopefully be the easiest and a team effort. The idea is not to make more work, but to make our work that we're already doing more efficient. So placing less catheters, the way that the operating room has already done this, there's actually now straight cath kits available in all the cores, which was a huge feat by our operating room nurses to get there. And so they're there now, so use them if you can. And then the target for protocol placement. So if a case is less than 2 hours, really thinking about whether these catheters need to be placed. Early removal. So targeting protocol for early removal, as we just looked at here, it looks like the majority of the people taking the survey agreed that cases that were less than 4 hours would be applicable for catheters coming out. And then many replied actually any cases. Of course, there's going to be exceptions for patients that need hemodynamic monitoring, etc. But early removal looks like it would be a great target. How we're going to propose doing this is actually through order sets, and this is actually probably going to be initiated by our perioperative nurses. So an order for a catheter is actually going to be put in by the nurses, and then this would hopefully trigger a postoperative order set in Epic for the resident that's putting in, or APP putting in the orders. This is a little bit complicated and has been on hold because of other events going on in the hospital as far as our order set, but we are going to work very closely with Epic to try and make this as seamless as possible. All of us are supposed to be using our postoperative timeout, and actually drains that the patient is leaving the operating room with are of this timeout. So including these drains in that would be including catheter. So when you talk about the catheter, when is the plan for it to come out? And the last one here is post-op nurse-driven protocol. This is what the non-surgical areas are using. So we're going to also explore this as well. The third part is place better. So place less, early removal, and place better. So this is going to be a 2-person verification in the operating room. So utilizing our scrub techs for exactly what they are there for is sterility. So observing whoever's placing the catheter and just verifying that there's no breach in sterile technique while it's being placed. So this is the nurse-driven indwelling urinary catheter removal protocol that's being used everywhere in the hospital. So this has actually already been implemented. It was already placed before our peri-op task force was convened. And so the link to this is on the bottom, or if you go to the source and search urinary catheter, you would find this. So this is just details what you do to see if a patient is in retention after that catheter comes out. So even if the nurse is not driving the removal for the catheter placement, the protocols that they can follow if they are concerned that a patient is in retention or having some sort of needs for monitoring of urine output, patients would fall under this, and you can always refer the nurses to this. This is supposed to be something that they all have access to and can all follow. So I'd like to thank our team, specifically Ethan Kumbler, who's a mentor to all of us on this project. We have a wide representation of people across the hospital helping with this, and everybody has really provided some very significant, valuable input. So at this point, I'll take some questions and comments.
Okay, Janet, that was great and an extremely important topic. And not only does it affect, obviously, UTI rates within the hospital, but it affects overall payments to the hospital. It affects where we end up on U.S. News and World Report rankings, and it affects really everything globally because CAUTIs are one of the major drivers of all of these things. So this is a titan that you've taken on, and thank you so much for your leadership. Now, we actually have about 7 minutes, so why don't I call on people to ask their questions. So, Dr. Meacham, you had a comment and a question.
Yeah, Janet, this was a really, really nice, a great presentation on, I agree with what Dr. Schulich said. It's a very, very important topic. My question is, a lot of us, many clinicians are involved in what I feel to be important quality and safety initiatives, and certainly our patients are benefiting from these every day. You've been successful in turning efforts such as this into important, highly successful, and actually very productive research projects. Can you give a little bit of advice to others who are on the call today, who are in the session today, who would like to develop formal research opportunities in this area and kind of take it to the next step academically?
Yeah, thank you for that question. So I think there's a good structure around it. So the first thing that you want to do is you think about what the problem is and what your baseline of the problem is. I think the simplest thing to do for quality improvement research is to really evaluate where you're at for your baseline, implement your change, and then evaluate your change afterwards. It's going to give you some good publications if you can demonstrate that you've made a significant change. Now, of course, it's not a randomized controlled trial, but those are often fairly expensive to do, and doing it more as a cohort study is actually a fairly cheap way to do it, and you get your quality initiative implemented right away so that you can start making those changes.
Great.
Thank you.
Thank you. Flynn's comment/question is, consider suprapubic catheter instead of Foley if patient will need the catheter for more than 14 days. Also, BID cleansing of catheters, especially in ICU, has been shown to be effective. Janet, can you comment on those?
Yes, so the catheter cleansing is part of the nursing workflow right now. So I will get with nursing, and thank you for that comment, and make sure that it is BID. As far as patients needing catheters for more than 14 days, I would say the majority of those patients, urology should be involved in their care. I can't imagine that people would plan for a catheter being in for more than 14 days when urology isn't involved, but we're always happy to be involved if someone would like us to be there and place suprapubic tubes for those reasons.
Okay. So actually, I think a lot of the surgical oncologists and maybe colorectal surgeons and other surgeons who have complicated patients sometimes do have patients with catheters for more than 14 days. And we don't actually always think about calling the urology team. Maybe this is something that we should be discussing and looking at more.
Yeah, I think all of us would probably be happy in assisting management of these patients.
Okay, great. And then I actually had a question. So when you actually look at the top 10 performers, the hospitals that you listed, how are we different from them? I mean, which are the areas that where we do things so differently that you think that's what's leading to our issues?
Yeah, so it was actually very interesting. The ones that we got responses from, actually, the responses were not the same. So they didn't have the same plans in place. What most of them said is that they got buy-in very early on from all of their faculty, and they all had fairly strict protocols in that if somebody developed body, it was then kind of like almost a root cause analysis that was done for that CAUTI to see if it's something that could have been done differently. They take CAUTIs very seriously, which is a little bit different than the environment that I've been in. Really, any place that I've ever worked is that, oh yeah, the patient had a urinary tract infection, but there was never, why did it happen? How could we have prevented this for each one that happened? So the goal of this is to have less than 3 per month, which is a totally attainable goal. And then once we have those ones, we go back and we look at, where did we go wrong? You know, is there something that we could have done differently? Is it inevitable, as the word cloud said? Yeah, maybe, but I propose to you that actually the majority of these are preventable. And so our goal is less than 3 a month. And I think if we really take it seriously as a department and in the perioperative environment, that we are really going to be able to reduce the number of CAUTIs that we have.
I couldn't agree more. If we go to best practices, we'll save lives. We'll save a lot of morbidity, a lot of suffering that our patients have to undergo. And then some other great side effects is we automatically will get more payment from the government because our rates are lower. Our rankings will rise at least several positions on U.S. News and World Report, Vizient, and all these other things. So we really need to take this seriously, and we look forward to more guidance on this. And thank you very much for taking this on.
Thank you.